I'm a professor of children's sleep medicine here in Southampton, in the Children's Hospital and in the university here. And I'm really delighted to be hosting or co-hosting this meeting today with the Down Syndrome Research Foundation in the UK. And that's Liz there, up just in the corner of my screen. I don't know where she's on your screen. And Liz is kindly helping out with recording the meeting today. And I'm really thrilled in a moment to be able to introduce Jas to you. So Dr. Jasneek Chawla is an associate professor of sleep medicine over in the University of Queensland in Brisbane, Australia. Now, Jas has, in the context of this meeting, a wealth of expertise and experience in managing sleep disorders in children with Down syndrome, and very recently has completed a PhD, a doctoral study looking at sleep, including some really innovative and interesting data on family perspectives, which is what she's going to talk to us about today. And alongside an incredibly busy clinical job, she's found the energy and time to do a lot of really exciting research and has just got herself an NHMRC, that's a very high profile research grant for 1.6 million Australian dollars to do further research in the field into sleep in children with neurodiversity. And what I really love about Jas's work is it's very practical, it's very pragmatic, and it's really family focused. So we're really excited to have Jas come to share. I'm going to hand over in a minute. She's sat right next to me to share all her lovely work. And Jas, I think you wanted people to just pop in the chat if you don't mind. Most of you will see there's a little chat button at the bottom. If you don't mind.
Just hang on a minute, guys. I think she got herself disconnected.
Thank you. Thank you for that introduction, and thank you all for thank you all for taking the time today to come and listen to me talk about something I'm very passionate about. As Kathy said, I am I have been doing some work for some time now looking at sleep in children with Down syndrome and focusing particularly on the family's perspectives today. So I'll just share my screen and hopefully you can see that. Okay, can I just check that you can see my slides there?
Yep.
Brilliant. Excellent. So as Kathy said, I'm really happy to answer questions towards the end of this. So you know, feel free to put questions into the chat for me, and I can answer those a bit later. So in Australia, we always do start with an acknowledgement of country. The University of Queensland and Children's Hospital of Queensland acknowledge the traditional owners and their custodians of the lands on which we meet and on which this work was conducted. And I pay respects to the ancestors and their descendants who continue cultural and spiritual connections to country. So it's a really significant thing for Australians to recognise the First Nations communities that have been a big part of the Australian heritage. So as you will all well know, sleep problems are really common in children with Down syndrome. We see a myriad of things in this group of children. Obstructive sleep apnea is obviously something that is very well recognised. It's approximately, from the literature, 6 times more common than in typically developing children, and of course results from their characteristic facial features, the mid-face hyperplasia, the large tongue, and the low tone they experience. And one of the big things that's important to know in this group is that this often reoccurs and persists despite treatment. So it's quite a pervasive thing for families across the child's lifespan.
No, it wasn't you, Timmy.
Oops, not quite sure what that was.
No, I'm not sure who's doing that. But if you have an idea, let me know in the chat and I'll throw them out. Thanks.
Yeah, I can't.
Guys, if you unmute yourselves, everyone, it does not have the ability to unmute themselves any longer apart from ourselves, the 2 presenters.
unmute. There we go. Right. Okay, so if you look at information about the family's perspective on having a child with Down syndrome that has sleep problems, this is really not something that's been widely studied. In fact, when we started this study, we looked at the literature that was available, and there was only really one paper that had really thought about sleep. And this was a paper by Choi et al. It was a Korean group that had examined the impact of parental quality of life and shown a negative correlation between sleep problems in the child with Down syndrome and the quality of life of parents. But this was very much one little question within a whole host of things that they were studying. There are definitely other studies that have shown that having sleep problems in children with intellectual disability has negative impacts on the families, but this is clearly a very complex relationship. And there's a link of some sort between the sleep problems, the child's behavior, the parent stress levels, and an awful lot of different things that feed into this. In 2020, this group, Varma et al. Recommended that sleep problems in parents of children with sleep disturbance need to be addressed, as well as thinking about the child's sleep difficulties to try to improve mediating improvements in quality of life and mood. And that was really sort of recognizing that this is bi-directional. If you don't treat or don't help families and don't help parents, then the impact on children is going to be significant. So what we decided to do was a mixed method study, really, where we undertook both a qualitative and a quantitative component to try and understand a bit more about what goes on for families of children with Down syndrome who have sleep problems. So these were all families who were coming to the sleep clinic, and we undertook structured interviews using specific domains, and you can see there some of the domains that we were using, looking at sleep, looking at family dynamics, their access to supports, and their experiences of healthcare, which was actually quite revealing, as I'll show you. And then we also did a quantitative aspect where we asked the parents to complete the depression, anxiety and stress scale, and a quality of life questionnaire. And we used the same one that the Korean group had used in their study. We had 27 parents, and you'll see that majority of them were mothers rather than fathers. And we had 10 siblings. So we did a similar thing with siblings. They didn't fill in the questionnaires, but they did do the qualitative interviews. And we recruited them alongside their parents. They had the option to have their parent present at the time of the interview if they wished to, or they could do it independently. For parents, we also asked them to do an additional measure for us. And this is really just a bit of additional information. We asked them to think about their child's sleep across the lifespan. And so if their child was 4, we asked them to tell us about their child's sleep over each year of that 4 years. And similarly, if they were 12, we asked them to recall over 12 years. So bearing in mind some of this was recollection, but we got them to give us a bit of a pictorial overview of their child's sleep. So this here is, there we go. This here is just an example of the pictorial that we asked families to tell us about. So in each of these years, they were asked to give us a grading, if they could recall, of their child's sleep out of 5. And they were asked to then also additionally write any comments down about their child's sleep at that point in time. And I guess I wanted to start with this just to really show the sort of information that this actually gave us. So this is an example of one patient. And what you can see here is, so a higher score means that sleep was improved. And what you can see here is that this child started with a score that their parents graded around 3, dropped down, and at that point adenotonsillectomy was undertaken. And then you can see here a bit of a response to treatment where they have had an improvement in their sleep over time. What was actually more interesting than these sort of individual patient graphs was actually these comments that came through from families. And what we found is that in the first 5 years of life, there was very much this very strong focus on the breathing being the issue. Parents were very much focusing on the obstructive sleep apnea symptoms being stopping breathing, stridor, snoring, waking, tossing, turning with breathing related issues. But then as we moved to the sort of older age groups, we found that it was a little bit less breathing focused and much more focused on sort of routines and you know, needing parents to be around, sleeping in strange positions, wanting to have parents present while they were sleeping. So there was definitely a change that we noticed in our data. So that was just quite an interesting finding. So moving on from that, we sort of thought, well, let's think about what we learned from the interviews we did with parents and siblings. So we'll start with parents, and I'll just share some of the things that we found from these interviews. Okay, so first of all, the demographics of this population. We had, as I mentioned, just under 30 parents. You can see here the family structure. So we did have a predominant, you know, sort of nuclear family structure. You can see the age range of the children, and you can see that we did have a reasonable number of children over the age of 5. So a lot of these kids were actually a little bit older. There is a skew definitely to them being, you know, more highly educated and being more skilled in terms of their occupation type. So certainly we have got a skewed sample, and I think that's really important to recognise as well. So if I go first of all to the quantitative data before I dive into the parent interview data, we had 23 of the families fill out the 2 questionnaires that we asked them to complete. And this is the group data, and you can see here very clearly that they scored pretty highly from a depression, anxiety and stress level compared to norm. And in terms of their quality of life, they actually scored significantly lower than the general norms in all domains. So really strikingly showing us that there was quite an impact on having a child, presumably on having a child with Down syndrome, but certainly for these families, there was quite a significant a decrease in their overall function. So with the interview analysis, what we found was that parents certainly recognised that sleep was a significant comorbidity. They recognised a negative impact of sleep deprivation, giving them lower patience, barriers to their own self-care. Many of them expressed guilt for not having enough time for siblings. They interestingly told us that they'd received very minimal information about sleep being an issue for children with Down syndrome, and they had this feeling of not being listened to. And the big thing that came across to us was that very much they normalized these sleep problems in their children as a way of coping with the problems that they were facing. So this is really just a schematic that we put together to sort of explain what we found. So when we were exploring these domains, we explored parents' experiences of sleep and family dynamics, and parents' experiences in the healthcare system. The themes that we broadly found from our interviews with the families are shown here, and I'll go through these in a little bit more information. But we also sort of found this overarching theme and coping strategy of normalization. So if we go through these themes that were drawn out from our analysis, so we found that sleep disruption had an adverse and pervasive impact on parents' well-being and family dynamics. So, for example, parents were saying we stayed at home a lot because we were just too tired. They found it quite difficult to tease it out. So is it related to, you know, having a child altogether, or is it related to having a child with Down syndrome, or is it related to having a child with Down syndrome who has sleep problems? So they chose to have, you know, a comment was we chose to have children, which is kind of a choice to be tired. We also found that they were very, very strikingly telling us that they'd actually received quite insensitive and inadequate care when they sought treatment for their child's sleep. A paediatrician said, treat your son with dog commands. Healthcare professionals also contributed to this normalization of children's sleep difficulties. For example, paediatrician said there was no sleep referral needed, it's just normal. Sorry, I'm just having a few difficulties with my slides. There we go. So, so just to really show you some of those comments that came through, if we look first of all about the sort of effects of sleep disruption, this is a comment from one of our parents. I'm very grumpy when I'm tired. Tiredness for me is a big trigger. I eat worse, I'm grumpy, I get cross with the kids, I get more frustrated, and even more so when it's not my choice to be tired. As the bit I was talking about with not feeling like they could really separate out this being due to sleep, you know, this family were actually very able to do that. All the other manifestations of special needs, the sleep was the thing that impacted us all the most as a family. So I was tired to start with. And the child was tired as well. So yes, it was really hard to take yourself out of your body, observe yourself from outside, because you're immersed in it, it's your experience. And so, you know, I was just desperately trying to get through the day. Screen. Just, sorry, can I just check if you can still see my slides or not?
It's going intermittently black, and then it's coming back on again after a second.
Okay. All right. We'll just keep trying. I'll try not to touch too many things.
Switch the other screen off.
So in terms of parents' experiences when they try to look for treatment for the child's sleep problems. I'm sorry, I'm not quite sure what's happening here. I could try, let me just try swapping the screens over. Excuse me. Just try to do this. No, it's not gonna work. Yeah, I'll just reshare. Sorry. Let's try again. Sorry about that. So parents certainly described, sorry. That's what I was just wondering, if I can move it all onto this one.
Try again. I think it's someone has joined the meeting who was causing trouble. They've been removed. I have never had this happen before in any webinar I've ever been on, so I think we're just unlucky today. But I think with the help of some of the people who are here, they've let us know who it was. So we hopefully removed any troublemaker, but I don't know how they were doing it.
Okay. All right, we'll try now. I apologize for that. So parents certainly described encountering insensitive and inadequate treatment when seeking treatment for their child's sleep difficulties. So for example, one described, I had the paediatrician say to me, what's the point of a sleep study? She's never going to be able to wear face masks. She's never going to be able to cope with that. So I'm not sure why we would send her for a sleep study. What's that going to achieve? So certainly this, you know, sort of experience of feeling quite dismissed by healthcare. And following on from that, health professionals, you know, contributing to normalization of children's sleep difficulties. So I spoke to the paediatrician about it and he was like, oh no, don't worry, no sleep referrals needed. It's normal. It was actually my GP who was ENT trained before she went into GP land that said, actually, it's not good. It's not normal and her tonsils are huge. So she ended up pushing for the referral because my GP didn't even, because the paediatrician didn't even want to refer to ENT. So what I've done here is, what I'd like to share with you is some of the ways in which we've put this, this data together to really show the experiences of families. And we've used a technique called DRAW, which is departing radically from academic writing. And I have to thank Dr. Emma Cook, who's my qualitative expert and a sociologist. I'd like to share some of her poetry that she's put together. And this was about families' experiences at the moment of diagnosis. A traveling person did the scans. Doctor, they gave Janie the option, terminating. She wanted a live baby. 13 years, that's where we left things. Pregnant, waited so long, packed bags, scan, moved into mum's shed, counselling mum along. First scan, 20 weeks, doctor called, is someone home with you? Don't want you to panic, a chance baby might have Down syndrome. My ex didn't want children, then Ralph said, let's have kids, meant to be. 21 weeks, diagnosis, changed perception, a week of grief. Test, I was like, yeah, whatever, put up with all this shit. Do you want to get rid of her? We can organise it. Told I can never have children, love unconditionally, told over the phone, by myself. I said, what? What do you mean? They didn't have to raise it with us. High risk, I saw her. We knew. Raised it with them, 24 hours, special care support us through. He took me to a room and said, I believe you've got suspicions. Midwives, they both knew, but couldn't say. Need to fly you to Brisbane. Midwife knew the moment she saw. The doctor couldn't see. 3 weeks, quite jaundice. Nurse, she knew, sent me to the GP. Never offered the testing. 4 weeks, breathing, doctors standing there. They've known since he was born. Nurse came in. Are you going to tell her? 2, 3 months old, stopped breathing. He was expecting us to say because other parents he did see, they didn't want the baby. So what I really wanted to show here is that we were really asking these families about sleep, but we got this really powerful data about some of the other experiences families had had with healthcare. What we realized from this is that there is a lot more that we need to do to raise clinicians' awareness, not just of the sleep side of things, but on the impact that things like a negative experience at diagnosis can have on families long term. We found that sleep definitely is something that we know is modifiable, and it has profound flow-on effects if we don't actually consider treating it. We need to think about screening, and we need to think about targeting that, because parents may actually not disclose this, particularly if you don't ask about it. And we definitely need to think about how we promote cultural change, intolerance of prejudice in healthcare. And we need to remind everyone that sleep problems in children with Down syndrome are preventable, are prevalent and are treatable. So just from the diagnosis perspective, just to really go a little bit off topic, but to explain that from that work that we did, we have worked with Down Syndrome Queensland to develop a resource for health professionals who are dealing with providing a diagnosis, prenatal diagnosis of a genetic syndrome. And we've put together this website with multiple resources for both families and for healthcare professionals. And our group are currently doing some qualitative interviews with GPs and maternal health specialists who give diagnosis and asking them about their experiences, and then looking at how this resource may help to improve things. So this was something that came from unexpectedly from the work we were doing. So let's talk a little bit about siblings. So the first thing to say is that there are many benefits that siblings may experience from having a sibling with Down syndrome. And we say that just because much of what I'm going to present may seem like it's quite negative. But we do know that siblings can experience adverse effects from sleep disruption if this is not addressed. So with our siblings, we had 10 siblings of children with Down syndrome who ranged between 5 to 15 years. They were, as I mentioned, recruited alongside the parent cohort. The interview domains were similar to what we did with parents. We asked about their relationships with their sibling, with their parents, their sleep and their sibling sleep, their daytime function, and also the family functioning, and how they felt about these things. So here's a schematic that really kind of tries to show what we found in these children. So what we found was that these siblings were quite aware of having some adverse effects from sleep disruption. So they had difficulty functioning, bodily function, bodily fatigue, difficulty focusing, and they definitely noticed this. And they described this being quite overlapping, that there was really it was a kind of complex relationship between their sleep, their parents' sleep, and their child's sleep. And I'll show that a little bit more as I go through. But they very much had this attitude of resignation. They sought to settle the child with Down syndrome, used self-soothing strategies, and really used a bit of a toolkit of their own to try and cope with their sleep disruption. This is a comment from one of the siblings, you know, like, when I wake up, I just don't want to move any bit of my body or do anything. And then eventually it's a school day. Mum will go, you have to get up, it's a school day. And then I'll just, like, when I stand up, I might feel wobbly and stuff on my feet. But they definitely reviewed this in a relational way. So, you know, here's a really pertinent comment from a child. I came out and sat with the child with Down syndrome from about 3 until probably about 7 in the morning, reading her books because I knew that mum needed sleep. And the way they cope, I just try and focus on another sound. It helps me. Sometimes I hear the rushing of blood through my ear when I'm lying down. I try and focus on that. Then what was interesting is that when we were looking at the parents' view of the siblings' experience of sleep disruption, parents are really only describing the tip of the iceberg. So what we see with parents is that parents are recognizing that siblings had difficulties in functioning and had these emotional dysregulation that we could see. But the parents were actually attributing this a lot of the time to other things, you know, to the child's temperament, to hormones, to stress, to age, you know, to their mental health, but didn't actually perceive this as being due to sleep. However, and we found that parents were really underestimating siblings' sleep disruption. A mother reported that being woken up by the child with Down syndrome doesn't happen very often with the siblings. It's lately more me. The elder sibling did say it doesn't happen as much as it used to now, but that contrasted the report from a younger sibling who relayed that she was woken up by the child with Down syndrome once or twice a week. So you can see here how there's this real discrepancy between what the family members were saying. And here's an example of how the parents attributed these symptoms to other causes. I've currently got her seeing a counsellor at school. She's definitely going through something. Jolie has anxiety, a very stressed, angry child. She will just cry and say she's tired. A lot of it's obviously because day-to-day life with a child with Down syndrome. When she has time away, so she'll go to my mum's house or something, she's just totally different, more happy, not stressed, sleeping, actually sleeping into a normal time. And it's interesting here because the parents recognizing that the child sleeps better in her mother's house, but doesn't actually link that to the fact that the child is actually functioning a lot better. So our key findings from the siblings were really that all the participants did report interrupted and poor sleep caused by their sibling with Down syndrome, and that they recognized that it negatively affected their daytime behavior and family function. But we did see discrepancies between the parents and the siblings' accounts. Parents were underreporting how the siblings were impacted, and the siblings had greater insight into family functions than the parents suggested. And the family context was important. So those that reported a close bond with their sibling with Down syndrome also reported more nighttime disruptions and taking more of a caretaker role. But they were also more satisfied with their family relationships and dynamics. So certainly it was very interesting to see these reports. And I wanted to put this in, which is another poem by my colleague about, and the names here are all pseudonyms, so they're not real names, but this is a poem that I'd like to read to you that really describes the things that they learn from children with Down syndrome as well, and the positive side of it. Expect the unexpected, anything could happen. Advice cradled in laughs. If they're scared, you might have to comfort them for a little while, longer than other kids. Be patient, because they're not going to get everything like that. When they go shopping, he usually doesn't want to leave the toy aisle and sort of makes a big scene. They don't usually bring Byron food shopping because he'll ask for everything, the lollies and the chocolates. Sometimes Skylar does ask Delilah, what would it be like if Byron didn't have Down syndrome? And Delilah would usually answer, a lot different to what we are now. how much less rushed mum would be trying to get him ready for school. Passed down to them by their parents, wrapped in a shiny green bow, Skylar and Delilah receive the story of luck. They're really lucky because he hasn't got any heart problems, he can feed himself, he can get dressed, and he can do a lot of things that kids without Down syndrome would be able to do. They have confidence when it comes to being a role model at school. A lot of the other kids are a lot easier to handle than him. So if you learn how to do it the harder way, it's pretty easy to do it the easier way. They've learned a lot of sign language with him. He comes home with all these different words. They've learned other things from Byron too, to not give up. He'll give it another shot and he might get it. He might not, but he keeps trying. So to summarize all of this, we know that sleep is a modifiable factor that affects health and well-being of the entire family. We really do need to look at improving psychosocial supports for parents and families of children with Down syndrome. I think the voices of these siblings are often quite unheard and do require more evaluation. And I think we do need to consider how we improve awareness amongst health professionals regarding the impact of sleep problems in this cohort of children. And I'll remind you of this quote that I really think is quite unacceptable. You know, we went to the paediatrician constantly. I remember crying because I did have a mental breakdown. He's not sleeping. He wouldn't believe us and would just say we needed to treat him with dog commands. So to finally end, I thought I would finish by this beautiful poem that Dr. Cook wrote for my thesis for me. The impact is pervasive, yet it often goes unstated. Tiredness and parenting are warily conflated. Parents feel their patience wane with their mental health depleted. Despite adverse effects, sleep problems are still not treated. You may ask, well then, why not? They normalize so they can cope. Sleep disruption as a concept is as slippery as soap. Tired from sleep disruption, or is it from their busy days, or aging, failing fitness, appointments, stress, or just a phase? When parents do seek treatment, quality of healthcare varies. Sadly, sometimes clinicians become parents' adversaries. Parents feel not listened to. Seeking help, it is distressing. Insensitive responses when sleep problems need addressing. Be wary, clinicians. Normalizing problems with sleep. Prejudice can blind you. For treatment options, parents weep. Sleep is modifiable. Sleep has profound flow-on effects. Clinicians need to know this and should treat families with respect. Since parents normalize, we need targeted sleep screening. Parents may not speak up, need clinicians intervening. We need healthcare cultural change, no prejudice tolerated. We really must move forward from cruel views that are outdated. Sleep problems are prevalent amongst children with Down syndrome. Sleep problems are treatable. You should now know that from this poem. So I'd just like to end by showing you some work that we have just started and just received some small funding for, which is really looking at trying to really understand this family voice of children with, of families of children with a disability. And this is a project that I'm undertaking with a collaborative group and in partnership with Down Syndrome Queensland. And we are looking at doing a co-design program. We want to deliver a workshop on the road similar to this, showing families the findings that we have found from our research, but we want to really try and tap into some of the more disadvantaged areas in Greater Brisbane. And we want to undertake some focus group activities to really try and understand the priorities for families from education, social services and health, and obviously bringing sleep into that. And our ideal is that we can work with consumers to try and understand where we should drive research and where the priorities need to be to try and help families of children with Down syndrome and other disabilities. So I couldn't undertake this work without the support of all the families of children with Down syndrome within the Greater Brisbane area. Obviously Down Syndrome Queensland, Down Syndrome Australia have been incredible supports to me. My qualitative academic colleagues particularly Emma Cook, who has written these wonderful poems that have been really powerful in getting across some of the parents' perspectives and siblings' perspectives. I've been supported by an incredible team of people with supervisors, mentors, my sleep team, and my research team, and obviously from my funding partners. So I will stop there, and I'm happy to answer any questions, and I do apologise for the technical issues that we had. Yeah. Just stop sharing.
Thank you, Jazz. I wonder if, I think I've gotten rid of all the troublemakers. People can maybe put their hands up if they have questions, and I can, or put your questions in the chat. But Jazz, thank you very much. I'm a sibling, so it was lovely to hear the siblings' experience shared. My brother slept through, so I can't say I identified with some of those concerns, but it's lovely to hear the sibling voice there in research. Any questions from, oh, Zoe, I'll invite you to unmute.
Hi, thanks for that presentation. Really brilliant to hear, and how much is being put into learning more about this. So my daughter, she's 4.5, and has always had problems, and she used to have a stridor. Things have improved there, but is there, like, I don't know if you can actually answer this, I do apologize if not. Is it possible for tonsils to grow as they grow and then become more restrictive? Because I saw you saying about having adenoids and removed, is it, and that sort of thing. Because her sleep is getting worse and I'm exhausted.
Yeah, look, it's definitely possible to have issues from the airway perspective with tonsils, with adenoids which sit at the back of the nose, but also with additional issues that can go on in the airway. So it's certainly worth asking to be assessed and reviewed from that perspective. So I think Kathy may be able to tell you better than me the referral process in the UK, because there are differences between Australia and the UK. But
yeah. I mean, I think, sorry, we're on this funny sort of screen where we appear and disappear. Yes, so I think it depends a little bit whereabouts you live in the UK, but I mean, hopefully you've got a community paediatrician who should be able to refer up to your local children's hospital for screening for sleep disordered breathing. And I think, you know, there's a big debate going on at the moment about how often we should screen children, should we, you know, how regularly we should do it through their lives. But, you know, all children should be screened at least once, certainly in the early years. That's certainly the sort of international agreement, but possibly more often. And I think, you know, as Jazz said right at the very beginning of the talk, with sleep disordered breathing, we know it's not just a problem of little children. We know that it remains a problem throughout life and sometimes into adulthood in Down syndrome, because it's not just a simple story of tonsils and adenoids. There's a whole lot of other stuff going on. So I think the main message I think all paediatricians would probably give is, you know, if you're worried as a parent, that needs to be taken seriously. The problem for any doctor in a clinic in the day is you can't see sleep apnea. You know, when a child's awake, you're not going to see sleep apnea. And you really can't make an accurate judgment based on what you see in the clinic. You know, so some children with enormous tonsils are fine. Some children with tiny tonsils still have sleep apnea. So, you know, no matter what, if you're worried as a parent, and if your child is sort of, you know, gasping at night or snoring heavily or having pauses in their breathing, you know, if they're kind of restless and sweaty and all of these sort of things, if you're worried, then it's about, you know, that really tricky thing of advocacy and pushing and you know, and getting a sleep study done, because it's really only a sleep study that's going to show one way or another whether there's a problem.
Yeah, definitely. And, you know, I think there's another question there in the chat just about, you know, whether as you get older, whether it's, you know, more likely to be the more habitual than physical problems. I think the message there is that it can still be both. And, you know, we certainly do see that older children can have the breathing issues as well. So I think the important thing is that you, if you have any of those symptoms that Kathy was mentioning, that you do consider trying to get referred in to get reviewed and to have sleep assessment done by someone who has the experience to do that for you. But you see both, and you certainly see both types of problems. And there are multiple different things that go on in sleep for children with Down syndrome and those with other disabilities. So it's really important to look at that holistically, rather than just focusing in on one bit of it.
Thanks, Zoe. Just Kathy, prepare yourself. They're asking if there's similar things going on in the UK. Just before you step in and give a little bit of a plug for what you're up to. I just wanted to flag as well for those of you who are representing adults or children who are getting into adolescence, that when you go in to see your GP and you ask for sleep apnea study, they may automatically reach for questionnaires that they use in the non-Down syndrome population. And I think it's important to remind them that those surveys and questionnaires are not validated. That means we don't know that they work in our adults with Down syndrome, so that they can be reassured they can make a referral for a sleep study just based upon them having Down syndrome. Okay, you don't need to put together a measurement of the neck and all of this sort of complicated things that one might do if you're an adult falling asleep at the wheel who doesn't have Down, those kind of typical presentations that they see of sleep apnea. It's different for Down syndrome. Those questionnaires are not going to be your ticket to a sleep study, so not to worry about that. Anyway, Kathy, they want to know, is there similar things going on in the UK?
I'm sorry, I'm kind of popping in and out of the screen here. This is our little fancy background. Yeah, so we've here in Southampton, and actually linking up with some other great centres around the UK in Sheffield and London, we've done some research over the years looking at sleep apnea in particular, but sleep problems more broadly. And I've noticed Philippa's question there, which I'd like to come back to, Liz, in a second. But, you know, we are really aware that we need to get smarter in the NHS in managing sleep apnea as a starting point in children with Down syndrome. And we're in discussions at the moment with colleagues around the country and with something called a clinical trials unit here in Southampton. A clinical trials unit is the kind of powerhouse of expertise around running big research studies around setting up a trial to see how effective some of the treatments currently offered are in helping children with sleep apnea. So, you know, the go-to treatment for most children in the UK, if they've got, you know, visible enlarged tonsils and adenoids, is to have those removed. But believe it or not, there is no really good research evidence showing that that works. And there's quite a bit of evidence from a review that we're conducting, which shows that in around sort of 40–50% of children, depending on the age and stage, it actually doesn't work very well. So we're really keen to do a trial in that area. But I think where Jazz and I are both sort of increasingly interested is in the bigger picture. And I think that links to Philippa's question in the chat there, which was around, you know, by the age of 7, you know, if a child's not sleeping, is it all about apnea, or may there be other things going on? And I think the research world and the paediatric world in the past has been quite rightly very focused on sleep apnea because it is super important. But in being so focused on sleep apnea, I can see Jazz nodding, has kind of forgotten about all the other sleep problems. So, you know, we both run sleep clinics and we see a whole load of other problems that are more common in children with Down syndrome, including chronic insomnia. So you don't have to have sleep apnea to have insomnia. You can have insomnia for other reasons. And just being a child is a great reason for having insomnia. And being a child who may have some developmental delay or learning disabilities, that makes chronic insomnia much more likely. And that needs a very different and measured approach. So certainly we've done some work looking at data showing that what happens between parents and young children, this is the kind of preschoolers, at bedtime when a child has Down syndrome seems to be a little bit different to when children don't have Down syndrome. And in particular, what we found from our data was that parents are much more likely to be very actively engaged with their child, so much more likely to stay in the bedroom, to rock a child to sleep, to be much more present at bedtime. Now, is that chicken or is that egg? So what's going on there? And those children seem to have a lot more sleep difficulties. Now, is it that, you've got a child who's got a lot of sleep difficulties, so you're going to be there a lot more trying to help them go to sleep? Or is it because of sort of learned patterns of behavior that the child then struggles to sleep independently? And we haven't got a lot of time to go into all of this, but we know there's some quite nice evidence that shows that a really critical part of child development is learning that clever little trick to soothe yourself to sleep. Just those final sort of few minutes of nodding off when you go to sleep, making sure that whatever is in the bedroom at that point in time is going to be exactly the same when the child naturally wakes up in the night, which we all do and which they will do. And that's a little bit of factual information that a lot of parents don't realize. So if, for example, let's say there's music playing in the child's bedroom the moment they fall asleep, when they have their natural night wake up, sort of 2 or 3 hours later, the music's gone, they might find it a bit harder to fall back to sleep again. It's kind of logical if you think about it. And often, parents will put a lot of effort into settling a child to sleep at the beginning of the night. And it might work really, really well. Say, for example, the child might fall to sleep brilliantly cuddled in bed. But then, of course, when they wake up naturally in the night, which they will do multiple times, they can't do it on their own. So they're going to signal, they're going to call, they're going to come and find the parent. So there's a whole lot of really good techniques around trying to address some of these problems. That's just one problem. So I think, the point is sleep apnea is really, really important. We need to do a lot more work to get that right. But there's a whole lot of other sleep problems and that we're recognizing, including, movement disorders, insomnia, parasomnias, sleepwalking, sleep talking, all these kind of things. As you name your sleep disorder, and for most of them, they might be a problem. So I think, fundamentally, what we need to do is to be able to provide more expertise around the country, more people who understand about sleep, more people who understand about the specificity of sleep in children with Down syndrome. And Jazz is doing some really inspirational work in Australia on these lines. So we've got a lot of common interests and hoping to cross-fertilize a lot with what's going on.
Yeah. There's a question there about resources and where you can read up on things like this. And I'm sure Kathy has some resources that she uses as well. But certainly we did do some webinars and some fact sheets, which we put together with Down Syndrome Queensland and Down Syndrome Australia that are available through their websites. And I also work very closely with the Sleep Health Foundation in Australia. And you do have to be careful to put Australia in that one, because otherwise you'll get the US site. And there's some great fact sheets there as well. But the Down syndrome specific ones that we've done are available through the Australian organisations.
And I think, Liz, a lot of people are asking about tips, aren't they? And we did a webinar, can't remember when it was now, last year or the year before, which I think you've still got stored somewhere, haven't you?
I have. I've been putting it in the chat.
I
put the link in the chat. So yeah, and I will put this talk on our YouTube channel, as well as I'll put it on Facebook as well. Michelle's asking. But yeah, you did share a lot of great tips in that talk as well, and some sleep organizations. Kathy, a lot of parents are facing a wait for sleep studies. Is that just happening across the country, that there's a long waiting list for sleep?
Yeah, and can you see Jazz nodding as well?
Good question. Okay.
I think it's a global issue, I'll be honest.
Okay.
We've got huge wait lists, and some of the other work that I'm doing, which again Kathy and I have been talking very closely about, is looking at alternative ways in which we can try and screen for sleep breathing issues, and looking at non-invasive ways so that children don't have to go through having lots of monitoring put on as well. And I've been doing some work on that recently, which hopefully we'll be able to progress and produce some quite exciting results from in the near future. So watch this space for that one, and be very happy to come back and talk about that one at some time, perhaps from Australia though.
Yeah. 10 o'clock in the evening.
Yes. But yeah, I think it is. I mean, our wait lists are also exceptionally long across Australia. That's the problem we've faced as well.
Okay. And if people, obviously in that situation, a lot of times private clinics pop up, and some people can't afford to pay for their own sleep studies. But what should they be looking out for actually a real valid result from a private clinic? They want to can they get it remotely for children, or is that not validated that they do a sleep study at home for children?
That's a tricky one, isn't it?
Yeah, because I know there are people
to
out there
reckon
making
then,
money
I mean,
from
I
families.
think, you know, I suppose fundamentally, it's around the skill of the operator, isn't it? We do some home studies within the NHS. There are some challenges around the quality of home studies sometimes. So, you know, not all sleep studies are equal. That's the first thing to say. You know, the equipment's not equal. The expertise of the people that are scoring them is not equal. And I guess one of the sort of slight concerns about private practice, it may be fantastic, but you haven't quite got the same sort of peer review and regulation that you would have within an organisation like the NHS, for example. Doesn't mean so that's always perfect, of course. You know, all of these things are sort of subject to human error. But I think for, you know, we find, I'm interested in your experience, Jazz, but I think, you know, children who've got additional needs, sometimes, you know, we're very aware that these sleep studies can be quite challenging. Some families do really well with home studies, but some families do need those to be attended in a hospital where, you know, if the electrodes come off, there's somebody there on site who can put them back on again. Because at the end of the day, you know, it's the quality of the study. If you don't get a good quality study, if it's not enough hours of sleep captured, you can't be absolutely confident you've got reliable data.
Yeah, no, I definitely agree. I mean, we've just finished a piece of work that we're hoping will be published fairly soon that's looked at the tolerance of the sleep study equipment, so the sleep study leads and things within our lab setting. And we're very lucky to have a lab setting that we have, you know, very specialist, fantastic nursing staff who monitor those studies overnight and will replace leads and things. But we showed very clearly that children with neurodiversity, and particularly the children with Down syndrome, I will say, really struggled with tolerating the equipment far more than the neurotypical children, and you know, very clearly showed that this is not an ideal monitoring option for many of these children. And it definitely does depend on the quality of the staff and the experience of the staff to actually help ensure that the leads are kept on and that we get enough data to be able to make some clinical decisions based on the information we get. So my caution with private systems, and Australia has a bit more of a private setup than the UK, is always that, you know, particularly from a paediatric perspective, there isn't a great expertise, and we very much encourage families of children with additional needs to try and advocate for the need for expediting their care in the public system, because they require that additional specialist expertise for that monitoring to be done adequately. It doesn't always work, but we try very hard to try and push that more than the private side.
Yeah. And I often tell families to bear in mind that this is the beginning of their journey. If a sleep problem is diagnosed, the machines are expensive. You need ongoing monitoring. It's not just that like bit of paper getting the diagnosis and then you pick up your machine or buy it off Amazon. This is an ongoing kind of relationship that needs to be developed with the sleep team.
I've just noticed, Liz, that Hazel has popped a chat in. Hi, Hazel. I'd forgotten about that new service actually from Somnomedics. Do you want to just mention that, Hazel? Because I wonder if that's where the question came from originally from Liz. I don't know if Hazel's still here.
She is.
She may not have a microphone, perhaps. So Hazel Evans is one of my consultant colleagues here in Southampton, who is our respiratory specialist who does a lot of clinical work with. Here you are, Hazel. Oh, you are there.
Yeah, sorry, I've been unmuted now. I was muted and I couldn't say anything.
You're paralysed.
Basically, so we in the this is very relative to UK services, and I'm speaking as in my role as co-chair of the British Paediatric Sleep Society. There is a company that most of the UK paediatric centres purchase their equipment from for sleep services across the UK, and they have set up a private service. And that was highlighted to us because of some concerns that we had about it initially, but we have followed up with the company, and the company has changed its structure. And we met with them very recently, and we are much more reassured by the governance in place for their home sleep study service, which is available for children and adults. The adult service is massive, and it has a whole big team reporting sleep studies. In the paediatric service, it's much smaller, but there's a paediatric physiologist reporting the sleep studies, and they're being overseen by a respiratory paediatrician. And our conversations have included the fact that if services are overwhelmed regionally, then you can sort of subcontract out some of your sleep studies into that private sector. And it's certainly something that I know that some centres are exploring. So we did have initial concerns, but we've met with the company, and they have addressed our concerns, and we are definitely more reassured by it.
That's a fabulous update. Thank you, Hazel. And I guess it comes back, doesn't it, to, you know, at the end of the day, you want to know there's governance processes in place, and you've got appropriately trained and skilled people, wherever that is, whether it's NHS or private sector, who are doing the work. Thank you.
Okay, ladies, you're at time. Did you want to add anything else?
Well, I just want to thank Jazz for taking time out. She's here on a sort of flying visit around the UK, so we're really pleased we were able to, you know, capture her to come to my slightly unstable. We came in specially to thinking this was going to be a very stable connection, but I'm sorry we had the technical difficulties. But really appreciate you coming and sharing. I think you'll agree, just really innovative and creative and fantastic work, and it's just so lovely to see that sort of sibling and family days, which I think is so important.
Well, thank you very much, and thank you for the opportunity to present. And, you know, obviously very happy to you know, have any questions forwarded through that come up with Kathy. So
great, and thank you for recording, Liz.
Oh, that's all right. And on behalf of the community, as I always do, when I get to meet researchers who spend particular time and attention on our community, thank you so much for everything you're doing to forward medical knowledge for people and adults with Down syndrome. So thank you both.
Okay, thank you everybody.